Good evening, Nursing 303 students. This will be the last part of Chapter 69, so Part 3. And this PowerPoint is for Week 8 and Week 9. Week 9 coming up, actually starting tomorrow on Monday. So we have a question here. Is the following statement true or false? It is necessary to dress the neonate in a stockinette cap and take temperature often. We've talked a lot about this, about what? Keeping them warm, finding out what their temperature is. So true or false? True. Controlling the temperature of the neonate is often difficult. So keep them warm, and by putting the little cap on, it's going to keep them from losing as much heat. We need to know their temperature, so we take it often. Objective evidence. Okay, continuing. Remember, this chapter was about the high-risk newborn. And so we have what? It says potential complications in the high-risk newborn. We were looking at the different things that made a new baby at high risk. We had several new babies that would be at high risk. So some of the things that we're talking about that would make a newborn high risk would be what? The mother has complications. And since the mother has complications, this would also put the baby at risk. So what if the mother has an infection? Would that perhaps be a problem for the baby? Yes. So high risk categories, let's look at some of these. And I have some page numbers down here. We are on page 1125, but it says see box 69-4 and look at these potential complications. So before I start in with all this, I'm going to say that high risk categories, some of the categories that we would put these babies in would be metabolic disorders. What's a metabolic disorders? Metabolism, a disorder with metabolism. Would that be something like hypoglycemia? So I won't get into all of those different metabolic disorders, but know that that would be a category. Infections, baby has an infection, perhaps from the mother. That would be a category. Respiratory surfactant issues. And we talked about this. We talk about the lungs being immature on a newborn or being mature. If they are immature lungs, they do not have surfactant or enough surfactant so that every breath, the lungs, basically the alveoli, will collapse. So in order to take another breath in, kind of they're starting off from scratch. This is very tiring. Can't keep up for long. Cardiac abnormalities, something going on with the baby's heart, structure and or function. And then we also have what? Substance abuse by the mother, but now we have the newborn with the problem, the effects of this. So on this box 69-4 that I'm going to talk about, it says these are some of the causative factors, the causes for a baby to be in that category of being a high risk. Okay, so causative factors, box 69-4. You can look at this in your book. First one it talks about the mother of this newborn had chronic problems. These chronic problems before pregnancy, during pregnancy, and it gives you some examples, and we've talked about this before. The mother may have cardiac disorders. Remember, she has 20% more blood, has to be pumped around. this blood is leaving her body and going to the placenta and then going to the fetus. This is a heavy load for the heart. So when we talk about cardiac disorders, it kind of is nice to think of perhaps the mother, let's just say that she was, had a failing heart. We used to call it congestive heart failure. Now they just call it heart failure. So just think of something like that. What if she had kidney disease? Something going on with her kidneys, not her BUN may be higher, creatinine. What about the filtration rate? Probably be low. She could have also had hypertension carrying through into the pregnancy. Hypertension, when we think of that, we're thinking of the blood supply, once again, to the placenta and then to the fetus, and thinking about what hypertension does, the narrowing of arteries. Okay, woman is pregnant and she may have, as an example that we talked about, pregnancy-induced hypertension. That was the PIH, pregnancy-induced hypertension, high blood pressure, and preeclampsia. These would affect the fetus. These would affect the blood supply. These would affect the placenta, the oxygen, the nutrients, the glucose to the fetus. Perhaps the mother was not eating well. We talked about this, poor maternal nutrition. This could be before she was pregnant, during pregnancy. Doesn't necessarily mean that she's underweight and not getting enough to eat, but not getting the right balance. Perhaps not taking her prenatals, not getting her B vitamins, not getting her calcium, and so on. Intrauterine infection. If the mother has an infection in the uterus, this is the same little home that the baby has now, right? So not good. We also talked about substance abuse, including alcohol. So this could be cigarettes, alcohol, cocaine, meth, long list there. Maternal smoking and also secondhand smoke. What if she's pregnant with twins, triplets, quadruplets, etc.? Does this make the babies, the fetuses, more at risk? And then we talked about placenta. Remember some of the things we talked about? Placenta previa, placenta abruption. So some of those could happen. And obviously that is going to definitely put the fetus at risk. Congenital defects, we've talked about some of those. What about chromosomal abnormalities? Some of you wrote papers on different chromosomes that caused disorders in the newborn. It could also be that the newborn is not the correct gestational age, the weight, and so on. Okay, it says a newborn and a mother with diabetes, and this is kind of the one that we keep going back to because there are so many women that are diabetic and so many women with diabetes that want to get pregnant or have gotten pregnant, have had, pregnancies and newborns. So the newborn of a mother with diabetes. So diabetes is much more common now than it used to be. So it is a major metabolic disease. We talk about metabolism, metabolic disease, and you've already studied this as far as insulin and the pancreas and glucose and so on. So if she is diabetic and she gets pregnant, we are thinking that she will, or even if she gets becomes diabetic during the pregnancy, so gestational diabetes, it is considered a high risk pregnancy. So that would kind of go on to for us to think, okay, if we have a high risk pregnancy, then we will probably have, a high risk newborn also. So mother with diabetes, some of the things that we talked about before, macrosomia, that was a large baby, right? A large newborn, macrosomia. What about preterm birth? So just thinking about that preterm birth, we are thinking of a smaller baby, preterm birth before it was due. Respiratory distress syndrome. This can be either with a preterm birth or with a term birth. Respiratory distress syndrome. Something going on with the lungs? Distress. Baby's distressed. The breathing is distressed. You would be able to see this on the newborn. We also talked about hypoglycemia, low blood sugar, right after birth, usually. So pre-existing conditions, it could be type 1 diabetes, type 2 diabetes. Some of this is discussed in other chapters, it says. But okay, so what if lady gets pregnant, things are going well, and she finds out that she has gestational diabetes? When does this usually develop? And your book says that it develops during the last 3 months of a pregnancy. So something good to remember. Okay, the first 6 months went just fine. Last 3 months, gestational diabetes. So these last 3 months, the mother's blood sugar is going to go up, and the extra glucose, is that going to cross the placenta and go to the fetus? It is going to raise the blood sugar levels. And of course, then the fetus's little pancreas is going to make more insulin. And we know that then at birth, we don't have this high blood sugar because the baby is not getting the glucose from the mother, but its little pancreas is confused and continues to dump in insulin. So it may take several days for the infant's blood sugar to return to normal. So the pancreas has to adjust to the new levels of glucose in its blood. So think of hypoglycemia. If a newborn, we talked about some of the things that might show up. Remember, it isn't a given that there would be symptoms or even signs that you could notice. But if it was suffering from hypoglycemia, remember, this can result in seizures. So this really, really needs to be watched in any baby, but particularly in those of a diabetic mother. So oral glucose, intravenous glucose, you would need to be prepared to do that. You're going to be, if you were caring for one, be checking their glucose, usually doing a heel stick. Could be also a venous lab, but heel sticks are quite quick, and it would depend how much this was fluctuating and what the seriousness was. So some of the other things you would do, you're going to be monitoring calcium and magnesium levels. Didn't we talk about that? Okay, magnesium, you're giving magnesium and it gets too high. What are you going to give? Do you remember what that was when we were talking about preeclampsia and or eclampsia? Something you had to have handy. So magnesium and calcium, are they kind of in balance, or should be in balance, I would say? The newborn from a diabetic mother, and be kind of thinking of macrosomia here. It isn't always that, but what are we thinking that they would look like? Kind of chubby, kind of, you would think healthy, right? Kind of big, healthy, chubby. I don't know if chubby is the word, but they do say that they have extra fat on them, subcutaneous fat. You would also see that the placenta is larger. Yeah, I guess it would have to be larger to supply more, right? And the umbilical cord is also larger. Okay, so baby is usually large for gestational age, talking about the diabetic mother now and her baby, her fetus. So it would be covered with vernix caseosa, be plump, have a full face, bulky shoulders, and like I said, often have macrosomia. Other problems that a newborn from a diabetic mother might have: traumatic birth injuries. Now, any baby could have traumatic birth injuries. Why? Why in particular are they mentioning this from a diabetic mother? We said macrosomia, having a larger baby coming down the pelvis through the pelvic outlet. Would that perhaps cause traumatic birth injuries? It could. Hypoglycemia we talked about, glucose instability, just up or down. It is not stable. This pancreas is not adjusting quickly to what it needs as far as insulin. They could also have electrolyte disturbances, respiratory distress. I feel like I'm repeating myself because we've talked about all these. Okay, polycythemia with jaundice. Polycythemia, jaundice. So whenever you see jaundice, you are thinking of what? Bilirubin, an increase in bilirubin. The baby's going to look, what, we say jaundice, but yellowish skin, yellowish whites of the eyes. Remember, it's a pigment, so it is going to show up. Okay, so the mother that is diabetic, that is pregnant, is going to start having education from the very first trip in when she finds out she's pregnant or starts going to her practitioner. So she needs to know that she needs to keep her blood sugars level as much as possible within normal range. And remember, she's going to be taking insulin, would not be oral medications if she's type 2. So they would also have a diabetic specialist that would be helping with that, and probably a dietitian. They are going to, or you are going to monitor her blood sugar levels very closely during pregnancy. So maybe going in more often, getting checked. So nursing alert. Sometimes these are in red, sometimes they're not. You need to read all of them. All of these, that's where they get their questions from. If it's nursing alert, something you should know if you're going to be going on to school, graduating, and becoming a nurse. It said it is critical to differentiate between jitteriness caused by hyperglycemia, and we talked about that. The baby would be jittery, irritable. And it says, and what might be mistaken as shivering. Now, I know that you learned in lab that newborns don't shiver. They really don't have that ability for a while. So don't think they are shivering. If the newborn startles easy, like what? That moral reflex, if it kind of goes a little overboard on that, or has shaky movements, think hypoglycemia. Get a glucose level. Don't guess on it. Okay, diabetes. Lots with that. We have some respiratory disorders. These are easy to confuse. Respiratory, how would we know what's going on, right? We just know babies, what, having trouble breathing and all those things that we were looking for. So let's go for this first one, transient. What does transient mean? Like does it mean it comes and goes or it doesn't last long? Transient. It's not here forever. Transient tachypnea. What is tachypnea? We already know that baby might even be, how fast can they be breathing? Transient tachypnea. They are breathing fast of a newborn. Okay, so they are saying transient tachypnea of a newborn. It is usually transitory. It's not going to stay there, but it is respiratory distress. If we knew for sure that that's what it was, then we could, take a breath and kind of relax a little bit. We don't know for sure if that's what it is. It's not up to us to diagnose. But it says that usually the first couple hours after birth, that it would start in. And it says the greatest respiratory distress is going to be about 36 hours after birth. So what, about a day and a half or so? Respiratory distress. So having trouble breathing. And it says it's usually gone about the third day after birth, so about 72 hours. So why is it doing this? What is going on? And is this a normal thing? It kind of sounds normal if it's just transient. So remember when the newborn is born, and we said that a lot of that fluid, amniotic fluid, is down in the lungs, in the sinuses, et cetera, and it comes out when it comes through the birth canal. Some of it comes out, and then we suction them and so on. So some of it still has to come out, some of it has to be absorbed. And so it says the cause of this transient tachypnea, fast breathing of a newborn, is delayed absorption of fetal lung fluid after delivery. So as soon as that is absorbed or suctioned out, then this passes, and by day 3, things are looking good. So it says the most vulnerable, the most likely to have this happen is an infant delivered by cesarean section. Why would that be? If they are not coming through the birth canal, does that mean that they are not having that fluid squeezed out of them? If they have cesarean, they don't go through that. So more likely to happen, they have more fluid there that has not been expelled. So they don't have the benefit, your book says, of compression of the thoracic cavity. And okay, so if they are delivered by the vaginal birth canal, most of the lung fluid is eliminated as part of the birthing process. What are some others that might be at risk for this? It says that if they were preterm or if they're small, if their mothers have asthma or if they smoke during pregnancy. So a lot of this and that, but just kind of know what it is. It's like I say, you're not going to diagnose it. If your baby that you're watching is having trouble breathing fast, you need to bring it to the provider's attention. So what are they saying? It says diagnosis is made when the infant demonstrates mild respiratory distress. It's not turning blue. It's not grunting and laboring. And it has a sustained respiratory rate of greater than 60 breaths per minute. Didn't we talk about this? That it was okay if they had a respiratory rate of 60 breaths a minute, but after after 2 hours old, that's too fast. So tachypnea, fast breathing, greater than 60. So it does say mild retractions, respiratory grunting, nasal flaring, and cyanosis may occur. But remember, this is not presenting as something really serious. It also says it might have trouble feeding them. Why would that be? Is it hard to swallow and suck and be breathing at the same time when you're doing it that fast? So they could do ABGs, arterial blood gases are going to actually give an accurate number for oxygenation and carbon dioxide. So that would probably show low oxygen levels, high carbon dioxide levels. They could also do a chest x-ray, find out is there fluid down in the lungs? Okay. Usually we give oxygen for that. Of course, we're going to be doing oxygen saturation levels, taking their vital signs. They may not be able to have the baby nurse or even suckle at all. So they may have to give IV fluids or use a feeding tube just to get them through this. So they may get tired of breathing, right? Tired of breathing, get tired easily. You need to watch them closely because respiratory arrest, don't we learn that about children? Quite often it's not their heart that is the problem. It is their breathing. They quit breathing. So the problem with this transient tachypnea is that when it starts out, it is really similar to the one below it, respiratory distress syndrome, that we know is bad. So how do we tell the difference? What do we do about that? Your book says that more serious disorders such as respiratory distress syndrome and group B streptococcal pneumonia, they have similar initial findings. So you need to be watching, monitoring, assessing, and documenting this, bringing it to the attention of the care provider. So there can be other things along with these respiratory disorders, such as the gestational age of the baby. Is it a preemie? Does the baby have an infection? How bad is this respiratory distress? So they may be given things like IV antibiotics. They may intubate the baby, put them on a ventilator. So it does depend on how bad this is. Okay, let's go to the respiratory distress syndrome. So that's the next one. So this is the one that we talked about several times. Often we see this in preemies, and it is a lack of alveolar surfactant. Remember, I said that this is what keeps the lungs slightly inflated. So gestational age and the level of surfactant are directly linked with post-birth survival of the newborn with respiratory distress syndrome. So how old is the baby? How old is the baby? And what is the level of surfactant? How mature are its lungs? The younger, the less surfactant, the less likely that it may survive. So they try to what? Woman is perhaps going into labor. This is when they might try to what? Give her something to even get a couple of days, a few days before she gives birth. So if they can delay it by giving medications so that the fetal lungs can become more mature. So what do they give? They can give As an example, betamethasone, a glucocorticosteroid, they give it 12 to 24 hours before the time of birth, and this helps reduce the severity. It helps to mature the baby's lungs. So if the baby does have respiratory distress syndrome, it was usually soon after birth, and it can get worse just within a few hours. So similar disorders, like I say, might be that transient tachypnea of the newborn and other kinds of pneumonia. So some of these present with very similar signs and symptoms. So what do? They can do a chest x-ray, and the clinical symptoms, so something you could see, of increasing respiratory distress, crackles. What is crackles? Crackles, does that mean there's some fluid in there? Generalized cyanosis, all over the whole body, generalized. And heart rates exceeding 150 beats per minute. Heart rate up, respiratory rate up, baby is blue. We see, we hear crackles, fluid in there. So they can find out the LS ratio and find out about the maturity of the lungs. Okay, if nothing is done to a baby that has respiratory distress syndrome, it will worsen and it may die. So this is when they would usually transfer the baby to NICU. And this is going to be very, I won't say complicated necessarily, it could be complicated. This would be having nursing care with probably many interventions and very close monitoring, doing things like giving antibiotics by IV, total parenteral nutrition, which is what, giving nutrition by an IV. And they would need to give them, what, a high concentration of oxygen? They need that, right? They need that to stay alive. They need that to keep from having brain damage, from not having enough oxygen. So when artificial surfactant is administered, and they do this by putting this down into the trachea, as soon as the lungs themselves mature, then usually the baby can recover and breathe on its own. But doing for the baby what it can't do. So providing oxygen, providing surfactant, keeping it from tiring out, like I say, by giving nutrition without the baby having to suck. So there's different ways that they can give oxygen. They can use a cannula. They can use a ventilator, and they can use it via an ET tube. So depending on how bad it is, the worse that this is, they would need to have, more invasive ways of handling it. They can also do CPAP, continuous positive airway pressure. So like I say, they can also give the surfactant. They put that down also so that it goes to the trachea. There's other ways that they can give oxygen. If they cannot give oxygen down into the lungs, they can also give oxygen right into the blood supply of the baby. So oxygen goes into the blood, and that is called extracorporeal membrane oxygenation. So they use a pump to circulate oxygenated blood. I guess that would be right. To circulate oxygen in the baby's blood by use of an artificial device. So this is kind of like heart-lung bypass support system. Okay, so we know that for a baby with respiratory distress syndrome, interventions need to be made. We know that it has to do with lack of surfactant. We need to give them oxygen. We have the next one that says retinopathy of prematurity, ROP. Retinopathy, we know, is something bad to do with the retina of the eye. Retinopathy, and it has to do with a premature baby. Okay, serious complication of the retina of the eye. You have this in term one. The retina is what actually we use. It is what nerve tissue. Goes right to the optic nerve. It's translating the light into nerve impulses. If you do not have a retina, then you are blind. You cannot see. So, serious complication of the retina of the eyes. When oxygen is given long term, or when it is given in very high concentrations, it can cause harm to the retina of the eye. And we call this retinopathy of prematurity because we are giving it to babies that are premature and need those high levels of oxygen. So it's usually a baby that's less than 28 weeks old, and varying degrees of blindness can occur. So this is like, what do? Give the oxygen and keep the baby alive, but perhaps cause blindness? Or do you not give the oxygen or as much and cause brain damage that would also last a lifetime for the baby? So why does this happen? What happens when you give oxygen like that? Why would that cause the retina to have a problem? So it says that the problem is caused by abnormal growth, scarring, and or detachment of immature retinal blood vessels. So it is the blood vessels of the eye in the retina that there's a problem with. So of course the nurse would be monitoring the oxygen, whatever it's set for, and try to keep them, as close to exactly what they are to be. And of course, there would be consultations then and later with an ophthalmologist, neonatal specialist. So if too much oxygen is given, like I say, retinopathy of prematurity could happen. Too much. Maybe not too much more than what is ordered, but too much for the infant to be able to handle, or for the retina to be able to handle. If too little is given, once again, irreversible brain damage can result. So they have done laser surgery on eyes and have been able to save the sight of many infants that were given oxygen. So remember, it can cause permanent blindness. So it needs to be monitored, used with extreme caution. Okay, so what is this next one? Choanal atresia. It is nothing to do with the anus. I already told you that. It sounds like it should be, but it isn't. So didn't we talk about esophageal atresia? Is that on here too? Let's see it. These are respiratory disorders. So, okay, newborn's nostrils. They're closed at the entrance to the throat. They go to take in a deep breath, and what happens? It goes in, just waves, and it's a dead end. So air can't get to the lungs. So that shouldn't seem so bad, right? Tell them to breathe through the mouth. Well, you can't really tell them, but didn't you think they would breathe through their mouth? No, they can't. So they cannot do this actually for a while, for I think it is 2 or 3 weeks. So it needs to be quickly corrected through surgery to open up the nostrils. So something to think about. Corneal atresia. It's going to be nostrils are closed, can't breathe, emergency situation. Meconium aspiration syndrome. Whenever we see syndrome, what does that mean? It means when you have a syndrome, if you have this and this and this, well, then you have that. Or that you have several things going on. So it isn't as simple as it seems. Serious condition. It could be in the fetus. They can aspirate meconium, right, even before birth. Or the newborn, or the newborn. It's mixed with the amniotic fluid. And what happens? Aspiration. This aspiration, does that mean that it is done into their lungs? So, meconium is what? That's your first bowel movement, meconium. Because it's thick, dark, greenish, black, pasty substance. So, at some point, the anal sphincter relaxes and it goes into the amniotic fluid. If the baby took the first breath before you suctioned, and this had happened, then the newborn might aspirate this meconium and the amniotic fluid into the lungs. Bad, bad situation. So if that happened, the airways, what? Are partially or completely blocked. And we have a I'm going to say it my way, hypoxic fetus, hypoxic newborn, cyanotic newborn. So basically what? Oxygen is not getting down there. You have the meconium, you have the amniotic fluid blocking. Remember ABCs, A, airway, no airway. So any aspirated fluid, atelectasis, what does that mean? The alveoli are what? Collapsing. Could be pneumonia or other things. So what would cause a baby to what? To loosen their anal sphincter at that point rather than waiting? So some of the risk factors, they say fetal distress, the baby's distressed. So I'm thinking, fetal distress, does that usually mean they're not getting enough oxygen? Is that when they're usually distressed? Okay. What about maternal history of diabetes? We always bring that up, right? Diabetics have a lot of, there's a lot of risk factors, or not factors, there's a lot of risks. There's a lot of problems or complications that can be caused by diabetes. Hypertension is another one, hypertension. Hypertension, not getting enough oxygen, distressed baby. Okay. Difficult delivery, intrauterine growth restriction. So just know a lot of risk factors for having the meconium aspiration syndrome. So I'm sure this happens, and then they figure, okay, what are some of the risk factors? And then they come up with some, statistics. They can do an X-ray and diagnose it, but also if you see meconium stained amniotic fluid, that usually is an indicator. So if a baby did have this, had aspirated meconium, you might find that they have a low APGAR score. You might find that they have cyanosis, they're blue. Apnea, not breathing. Tachypnea, breathing fast. Retractions, what were the retractions? Where the tissue, the skin between the ribs is kind of indented, sucked in. Hypothermia, cold. Hypoglycemia, low blood sugar. So remember, as soon as the head appears, or the face, I'll tell you as soon as the face appears, what do? You use the aspiration bulb syringe or wall suction, and you're clearing the mouth and upper respiratory passages. First thing that's done. Give oxygen, encourage fluids, and regulate temperature. They may put them on antibiotics. So if breathing doesn't begin quickly, what are they going to have to do? They're going to have to intubate, not you, but the healthcare provider, intubate the baby. And that way they can suction below the trachea. They can suction, remember the trachea is below what? The vocal cords or the larynx. So they're going down through the larynx into the trachea and into the bronchial tubes. This would be one where we talked about the extracorporeal membrane oxygenation, where they are oxygenating the blood, not the lungs, so that oxygen is carried around. So if the lungs are full of meconium and so on, they could just do the blood. Okay, last one, sudden infant death syndrome. So they used to call it, crib death. And so we're saying that this can happen from a newborn up to less than 1 year of age. Or, by the time it's a year old that day, I think it goes that it's not called that, but okay. So if they did an autopsy on the baby, they would not find a cause of death. In other words, that's why they call it sudden infant death syndrome. Baby appears to be healthy. Okay, so they're saying that SIDS is not as prevalent as it used to be, and that's because they are having mothers and fathers put the baby in the supine position. So what does that mean, supine? Lying on their back? So they say that you should avoid the prone position for sleep or putting them on their tummy until the age of 6 months. So what are some of the risk factors for sudden infant death syndrome? They're saying that low birth weight, so tiny baby, 1.5 pounds, something like that. A preterm birth, so it's also 6 weeks early. Maternal age of less than 20, so you have a 15-year-old having a baby, and she smoked during pregnancy. So symptoms are vague or non-existent. Apnea monitors can be used. This may be that the baby quits breathing, and so the parents are awakened immediately, go in and get it breathing. Parents sometimes are taught CPR. Okay, we're going on to, another question. Following statement true or false? Respiratory distress syndrome, and that was the one that had to do with the surfactant, and group B streptococcal pneumonia, which is a serious pneumonia, have similar initial findings. True or false? True. So they may be detected by early nursing observations and data collection. We have another question. Okay. This one, true or false? The nurse should obtain blood glucose level for a newborn experiencing jitteriness if the mother was administered Respiratory. So what's all that about? Do you remember when we talked about that? So we'll go to the answer instead of me explaining it, and I hope the answer will have it. So a newborn is jittery, and the mother was given a drug called Respiratory. Why was she given that? What did that do? What do we need to know about this? Okay. If the newborn startles easily, like extreme moral reflex, or shaky movements, think hypoglycemia. The mother is in the high-risk category for newborn hypoglycemia, as in the case when the mother received, ritodrine or tributaline to stop preterm labor. Okay. So all that makes sense? She got tributaline because this was preterm labor. And then what happened? Then baby born anyway, right? Okay. This one we've talked about also. More possible complications. Page 1126. Hyperbilirubinemia. So when we look at the very end of this, it says emia. We know that it's something to do with the blood. Go to the beginning of it, it says hyper, a lot, more, much, something like that. Then we see bilirubin, lots of bilirubin. We know that bilirubin is a pigment that does make us turn yellow, or cyanotic. But bilirubin is also something, a chemical, it's a pigment, a chemical, a byproduct when red blood cells break down. Okay, so we'll get into this. Oh, your book does explain it better than me, so I'll look at your book here. Bilirubin, yellow-colored pigment. It's released when red blood cells are broken open or destroyed, which is known as, now if you look at this, it looks like hemolysis. Hemolysis. Lysis means breaking apart. Hemo has to do with blood. But we don't pronounce it hemolysis, we pronounce it hemolysis. But it's okay if you say hemolysis, because that's actually what it looks like it should be. So during fetal growth, it says when the fetus is in the uterus, the placenta removes the bilirubin. Goes back to the mother, she gets rid of it, right? So red blood cell products like bile and bilirubin go through a variety of chemical processes, breaking down into different types of bile or bilirubin. So they go through the liver and back up into the bloodstream to the colon. So that is why feces have the color they do, is once again because of that pigment. If you did not have bile or bilirubin, then your feces would be gray, and we would know something's probably going on with your liver maybe. Okay. I'm not going to get into the different types of bilirubin here, unconjugated, uncombined, etc. I just want you to know that hyperbilirubinemia, it says it's a condition of too much bilirubin in the blood. And it often occurs, in a newborn. And the reason it occurs is because the immature liver is just not, up to speed yet. Maybe it can't manage the production and release of red blood cells. So the red blood cells are breaking down, enter the bloodstream, and we have elevated levels of bilirubin. Like I said, I don't think you need to get into unconjugated, conjugated, and so on. But anyway, the baby then would be yellow or jaundice. So physiologic, when you see physiologic, that really means physical jaundice. But they call it physiologic because it's a better word. But physical jaundice. It says it appears about the third day of life. So baby is what? 3 days old. We have both of them here. So just know this one. The physical jaundice, physiologic, is about the third day of life. If it appeared immediately after birth, then it is the one below, the pathologic, also called hemolytic disease. So we'll talk about this. Okay, I'm going to give you a little bit about bilirubin to know why it is such a big thing. Why do they even bring this up? So, if a baby has jaundice, has turned yellow, has bilirubin in their blood, and yes, it is showing, in their skin. If this is not treated, if it's just left alone, it can lead to brain damage. When it gets to be a certain level in the blood, it is causing problems with the brain. And the word for that is kernicterus. And it actually means bilirubin encephalopathy. So I used to take care of patients at the Veterans Hospital that were in end stages of liver disease, and they were all a very bright or deep yellow or even kind of a copper looking. Many of them that died there would have bilirubin encephalopathy. Yes, they did give them things to get rid of the bilirubin. But they also had different kinds of encephalopathy. But just know that this on a newborn that we're talking about is going to cause brain damage when it gets to a certain point. So what certain points, what do we need to know about that? Actually, children, babies, newborns can have higher levels of bilirubin than adults can. So normal bilirubin levels, they range from 2 to 10 milligrams per deciliter during the period of 3 to 5 days after birth. That's pretty high, but that's what they range from. So they do check for not just the bilirubin, but they check for the total, direct, indirect, etc. So the total, they're just talking about the conjugated, unconjugated, and they're saying that kernicterus, or the problem, it is so high that it is going to cause brain damage, and perhaps almost like a coma when it is around a level of 20, so about twice the high level. So we know then that we have physiologic or physical jaundice, and we have pathologic. So physical jaundice or physiologic, they say it's common. If the baby had a traumatic delivery, let's say it was a really long delivery, they had to use forceps to pull the baby out and so on. Are there going to be a lot of broken blood vessels, broken capillaries, a lot of blood erythrocytes, red blood cells that are broke, that are lysed, and you have a lot of what? Bilirubin going out into the bloodstream, because it's the contents, you might say, of these red blood cells as they are destroyed. So the byproducts of red blood cell damage, accumulation of bilirubin in the skin. We said it's a pigment that goes into the skin. So the physical jaundice or physiologic, it shows up in about 2 to 3 days after birth. It takes it a while. It takes it a while for these blood vessels, to release this and so on. Okay, so know that it is not immediate. And quite often it is caused from a traumatic delivery, broken blood vessels, broken blood cells, red blood cells. Okay, now we're going to go to pathologic jaundice. It is a hemolytic disorder. Hemolytic. It is a disorder and or disease, whatever, of red blood cells breaking open. Why would they do this? What disorders would be pathologic jaundice? So they do need to find out the degree of it, same way, like how much bilirubin is in the blood. So treatment for hyperbilirubinemia, it varies according to the results of the laboratory bilirubin tests. So they want to know, of course, the direct, indirect, etc. They need to find out what kind of a treatment they're going to do. So phototherapy may be indicated if the bilirubin is high. Phototherapy. What in the world would phototherapy do? So does phototherapy change the bilirubin from one type to another that can be eliminated by the body? Okay, the phototherapy, put them in an isolate, and it's equipped with special fluorescent overhead lights. They're going to take the clothes off the baby. Why do they have to do that? So some places will let them use a diaper. They shield the eyes from the ultraviolet light. They can also use a fiber optic blanket. So maybe used at home. And of course, you need to measure how much exposure the baby's getting from a light source. So needing to follow the instructions. Bilirubin levels need to be monitored, make sure that they're coming down. So if this is being done at home, what would the nurse need to tell the parents? Okay, could the baby get dehydrated being under this light? That's interesting. Dehydrated under a light. Okay, watch for dehydration. What about skin rashes? Did that happen too? What about hyperthermia? To grab a baby under a light, would it make it perhaps too warm? So just thinking, that there are some things like that that go on. So physiologic jaundice usually appears about the third day of life. Report any that appears immediately after birth, the pathologic jaundice. So an immediate cause of jaundice or pathologic jaundice is likely to indicate a hemolytic disease of the newborn. Okay, we're on page 1126. Neurologic complications, page 1127. So we're talking about what? Neurologic complications that happen during birth. Does this sound like it? Intracranial hemorrhage. Intra in the cranium results from difficult delivery. Precipitate labor, that means really quick labor, right? Precipitate labor and delivery, or prolonged labor. So like really, really quickly or really, really taking forever. We'll also talk about brachial plexus injury. This results from trauma during a difficult delivery, brachial plexus injury. And we also have facial paralysis, Bell palsy. And this is when the newborn's facial nerves are injured, usually as a result of forceps delivery. So we hear about some of these things. We hear about some of these with lawsuits, actually. So when we talk about neurologic complications, intraventricular hemorrhage occurs because the fragile capillaries and the pressure within the brain cause spontaneous bleeding into the ventricles of the brain. So you probably do not want bleeding into the ventricles of the brain. So this is because of what? The capillaries and the pressure, the cerebral pressure, spontaneous bleeding. What about, it can also be caused by sometimes life support, I shouldn't say life support, It's actually usually a ventilator for a newborn, can cause the pressure and have the same thing, the hemorrhage. So they're saying that this is a dangerous birth injury, the hemorrhage, for preterm newborns of less than 32 weeks gestation. So what are some other things of reasons that a baby would have bleeding, what, into the brain? So respiratory distress at birth, difficult delivery, and we talked about sudden precipitate delivery. Things just come out quick, or prolonged labor. So how would you know? You look at a newborn and they have things like pallor. Does that mean just pale? A pale baby, pale baby. They have bradycardia, a slow heart rate, or twitching. Twitching. That doesn't sound good, does it? But it could go on. They could go into convulsions. They could have bulging fontanelles. Would that mean pressure in there pushing out on them? They could be blue. So this has, let me kind of, I wanted to bring one thing up here. When we talk about something going on with the brain, which is the most important, the nervous system, it talks here again about a shrill cry. Also, if you measured the head, would the head perhaps be larger because of the extra blood in there? So they usually can do an ultrasound or a CT scan or an MRI and diagnose this. So of course the outcome would be how much injury has occurred and what they're going to do. So increased intracranial pressure. I know you talked about that before. Increased intracranial pressure. So in this case, it would be from blood, from bleeding. So one of the things that might, and you don't do this on your own, of course, you would follow protocol, but the baby had increased pressure in its head that you did not want to be there, of course. Would it help, do you think, to have the head of the bed slightly elevated? Remember, it's in this tiny, tiny little bed, right? Little incubator. If the head was slightly elevated, just thinking of gravity, that would take off some of the pressure because the head is more elevated than the body. For these infants, you do not want to stimulate them. No loud noises, no loud night, no bright lights. Get that out. Do not change any settings abruptly of any of the mechanical devices that might be. Be very careful about suctioning, sudden movements, jarring the baby. And of course, you're going to be monitoring closely. You're going to need to keep the acid-base balance. Acid-base balance. It's very, very important, right? So, giving them oxygen, vitamin K. What does vitamin K do again? Vitamin K. Every baby needs vitamin K, right? So it can make its own. So if they do not have vitamin K, what? They can bleed. This baby's already bleeding. So yes, vitamin K. Probably antibiotics, anticonvulsive medications, sedatives. They do not let the baby suck. It's going to be fed by gavage. So having usually a tube go down into the stomach. So if a baby did have intracranial hemorrhage, what could be the result of that? What are the effects? What does that mean? And it says that the complications that can result could be brain damage, so a CVA, cardiovascular accident, cerebral palsy. This would be movement disorders of all different types that are permanent. Hydrocephaly and mental retardation. So this could be very severe, having intracranial hemorrhage. Next one we have brachial plexus injury. And it says this one also results from trauma during a difficult delivery. So the one that your book tells you as an example is shoulder dystocia. So we learned about that. Of course, a baby can't be delivered if it is a shoulder presentation, but the shoulders do have to come out, one and then the other. So this also can cause problems. So we have others where there can be trauma to the 5th and 6th cranial nerves. And we have Herb Duchenne paralysis. And if you were not aware of this, what you would notice is that the baby is unable to elevate the affected arm. So moral reflex, what would it do? Would that be asymmetrical? It would not be able to do that. The arm would lie limply at the side, but the grasp reflex is present. So it could grab your finger, but it could not move its arm up. If it was a lower plexus injury, then it would have symptoms in the hand and forearm, and the grasp reflex would be absent. So you don't need to have all these memorized. Just know that this is what? Nerve injury. And perhaps it would involve range of motion exercises, splinting, and depending on the nerve damage, if it was severe or not severe, it may resolve or may be permanent. Last one we have is facial paralysis, Bell palsy. I'm sure you will see this again. And one of the things that you need to be aware of, if you were looking at a baby or an adult that had Bell palsy, where are we seeing this? How would we know? What would make us think that that might be what they have? So it says usually only one side of the face is affected, and the eyelid and mouth may droop on that side. So half the face, one eye, one side of the mouth. So it is a facial paralysis, and it is because the facial nerves have been injured. And this one, like I say, usually a result of forceps delivery. The paralysis may be permanent. It could also resolve. So if the mouth is involved, would that affect the baby being able to suck? So it would need special feeding. So the eye, if the eye is not able to close, if the eye is not able to keep the tears in there may be have to irrigate the eye and have patching to retain moisture. Don't want to have the cornea dry out. So plastic surgery sometimes can be done to improve the appearance, but it says most of these are only temporary. So the main thing is the nutritional needs of the infant. Okay, do we have more? Oh, this was pathologic jaundice, RH sensitization, ABO incompatibility. I will go over pathologic, let's see. Okay, pathologic jaundice, we talked about this. This is the bad one. We talked about RH sensitization. This is what the mother is what, RH negative, makes antibodies against the fetus. I mean, she could. We hope she doesn't. Hopefully we've given a program. But if this happens, RH sensitization, it says erythroblastosis fetalis, when an RH negative mother is pregnant with an RH positive fetus. So what is happening in that one? The woman's antibodies destroy the fetus's red blood cells. So if she did not receive the program at 28 weeks gestation, that this could happen. So if it did, then this is what they're talking about, that this would be obvious at birth. And of course would need to be treated, and we kind of talked about that. So this one would develop in less than 24 hours after birth, or even more quickly than that. And they, once again, would use phototherapy to treat it. And of course, we would need to watch out for having those high levels and connectors. The ABO incompatibility would be a mother that has a different blood type and the same thing happening. So the major blood groups are A, B, and O, and they're usually referred to as what? The ABO blood groups. So when we talk about the incompatibility, the newborn's red blood cells are positive for A or B antigens, or both of them, and the mother's red blood cells are usually negative for both of these. So more common, and in both of these, the woman builds up antibodies against the antigens from our own fetus. So good to kind of look through that. And okay, we have intrauterine disorders, congenital acquired infections. So what do we have? Fetal alcohol spectrum disorder, Down syndrome, and it says infections on next slide because the book kind of got this mixed up. I think I will actually stop here. I won't get into this because I didn't realize that this is going to be so long. I'm gonna break this up into another one. So this is the third one, and I'm gonna do number 4 in a day or so and put it up. So yeah, I guess I'll stop here, and we will have one more that will be a short one. So once again, if you have any questions, let me know. And of course, I will be talking to you on Tuesday. So I will put that on my IoT, and you'll know the time and so on. Okay, thank you. Bye-bye.